I'm glad today to welcome Dr. Kholoud. And please, Dr. Kholoud, share with us your experience about NIV and high flow nasal cannula.
Okay, thank you, Ahmed, for inviting me for this talk today. So my first slide says non-invasive ventilation in pediatric intensive care from a promising treatment to an established treatment. And that just summarizes the development that the pediatric non-invasive has gone through. So it started as something in observational trials, but now it has been the first respiratory support that we offer for critically ill children. So my initial slides, I'm going to go through the definitions and a bit of, about the earliest trials in non-invasive ventilation in pediatrics. So non-invasive ventilation is defined as delivery of gas through facial or nasal mask, which is an interface, connecting the ventilator to the patient's face and aiding delivery of pressurized air to the upper airway. So it's called non-invasive because it is basically avoiding instrumenting the trachea. With high flow nasal cannula, it's defined as administration of heated and humidified mixture of air and oxygen at a flow rate which is higher than the patient's inspiratory flow. So if you look at the diagram here, high flow devices would contain flow meters and an oxygen concentrator, and the flow of air and oxygen will be humidified and heated, and then it goes into circuits and tubings, and eventually it goes to the patients. So for infants, a flow rate which is more than 2 liters per minute is considered as a high flow. In children, a flow rate which is more than 6 liters per minute is considered as a high flow. The earliest trials in non-invasive ventilation came 2 decades ago, and we extrapolated the pediatric non-invasive studies from the adult studies. Initially, we had a very limited evidence because it came from observational studies, which looked at non-invasive as an outcome from an improvement of workup breathing. Probably the first randomized controlled trial came by Jans et al., and that was in 2008. We will be speaking briefly about that. As for the high flow nasal cannula, it increased in use in the last 2 decades. The initial trials on high flow nasal cannula came from neonatal population. So the first person was Shrinan, who published his experience with that. So this is one of the earliest published trials in the New England Journal of Medicine in 1998. So it came from the adult world. So this is a study that compares the use of non-invasive positive pressure ventilation and conventional mechanical ventilation in patients with acute respiratory failure. So in this group of patients, there were a mixed clinical diagnoses. So there were people with pneumonia, there were people with trauma, and all of them presented with respiratory distress. So if you look at the diagram here, we have 2 groups. We have the group who was put onto non-invasive ventilation and the group which was put onto conventional ventilator. And it is reasonable to think about it during that era because the norm for ICU was to intubate patients. So in this study, they basically looked whether non-invasive ventilation is going to produce the same beneficial effects as conventional ventilation. And therefore, we are here looking at oxygenation improvement. In pediatric critical care, we look at the so-called BF ratio. That stands for BO2 divided by the FiO2. And the higher the number, the better it is. The lesser the number, it just signifies that there is an acute lung injury and that the child is more hypoxic. So if you look at this, they started with the baseline for both groups. And both groups had their ratio below 200. And again, that indicates an acute lung injury. And then they followed that up in 60 minutes for both of the groups. And they found that both groups were able to increase their oxygenation. And therefore, the conventional ventilator had no superiority over the non-invasive ventilation. So in addition to that, they also studied whether there was a benefit in terms of infectious complications. So if you look here at the table, the people who developed pneumonia and sinusitis in the group which has invasive ventilation, were much higher, and that was statistically significant. So they concluded then that non-invasive ventilation was able to produce the same changes that a conventional ventilator would produce, and it had the advantage of reducing the infectious risk that comes with invasive ventilation. The next slide is about a pediatric study. So this came in the Pediatric Critical Care Medicine in 2008, and it was done by Jans et al. And basically that described the practice of, it described people who were put onto non-invasive ventilation versus standard treatment. So in this group, they randomized about 25 children to standard treatment. And a standard treatment included giving bronchodilators to asthmatic, IV antibiotics, and nebulized treatment, while the other group received the standard treatment plus non-invasive ventilation. And they followed them up. So if you look at here, this is the respiratory rate for both of the groups. Group 0 is the group that received only standard treatment. Group 1 is the group that received non-invasive ventilation. So this is the respiratory rate at the initiation of the trial, and this is 1 hour after. So basically we are looking at their means for respiratory rate plus their standard deviation. Now look at this. So if you look at the group that had non-invasive ventilation, their respiratory rate fell down after the first 1 hour of treatment, while those who were on the standard treatment who did not receive non-invasive ventilation, their respiratory rate remained high. Similarly, they looked at the respiratory rates, at the heart rate this time, and they found that the group who had non-invasive ventilation had a decline in their heart rate, which continued later on. So they basically concluded that those who showed response to non-invasive were able to reduce their work of breathing and to reduce their tachycardia as well, in comparison to the group who only had a standard treatment. So the other thing that they concluded was that the intubation in the group that received non-invasive ventilation was less. So the standard group had an intubation of 60%. The group that had non-invasive ventilation had 28% risk of intubation, 28% intubation. Therefore, and this was statistically significant. Now, the conclusion that the group had is NIV seems to afford patients protection from endotracheal intubation. And this is a very important wording. So if you look at the wording that they use protection against endotracheal intubation, because we know that those kind of patients, when they get intubated, they have the risk of developing other complications related to intensive care. So following these trials, there has been an increase in non-invasive and high-flow nasal cannula across the last 2 decades. And this is one example. So this was done by Gano et al., and it comes from the intensive care medicine. Basically, they looked at their use of non-invasive. So this is on a cohort of bronchiolitis patients. So they started using nasal CPAP, which increased over the years. With that, they documented their invasive ventilation, which came down. And this is something which is consistent in all the studies. So as you increase your non-invasive ventilation, the rate of invasive ventilation comes down. This is a study that describes the introduction of high-flow nasal cannula. So as high-flow nasal cannula increased over the years, the rate of invasive ventilation came down as well. And this is a third example. So when they started using high-flow nasal cannula in areas outside the intensive care, the need to escalate treatment to ICU was less as well. So overall, this is to say that these trials has shown an improvement in the uptake of respiratory support being in the form of non-invasive and high-flow nasal cannula. So over the last 2 decades, we had more and more people using this as their first respiratory support.
So Dr. Kholoud, in addition to whatever you have mentioned regarding the advantages of NIV and high flow in comparison to invasive ventilation, is there any extra advantages for the use of NIV and high flow nasal cannula?
Yeah, so let me go over these advantages overall. So the first thing we said, there's a reduction in the artificial airway, and this is one example where an increase in the non-invasive by 2.8% led to a drop in the intubation rate by 1.9% per year. So this is one example, and it's been emphasized before. The second thing that we spoke about was improvement in the gas exchange in responders to the treatment. Third is that basically you are reducing the risk of nosocomial infection. And there are some studies that also have shown that PICU length of stay decreases as well, that the risk the need for procedures, the need for instrumentation like central lines is less in the group that received non-invasive ventilation. So this is an example of that. This is a study which was done by Izur et al. It comes from intensive care medicine. And he looked at the PICU length of stay after introduction of non-invasive ventilation. So if you look at the top, this is a historical comparator. So they looked at their previous practice and they evaluated the PICU length of stay, which was 9 days. And after introduction of non-invasive ventilation, it dropped down to something like 5 days, and it was statistically significant. So basically, we're trying to say that the group that received non-invasive ventilation had less chances or less risk of having procedures like central line placement, as well as radiology. As a consequence, they also had less chances of nosocomial infections because they had less hardware into their airways. Overall, there was also reported reduced economic costs related to PICU stay, because if you look at the previous example, they demonstrated that the ICU stay has shortened with the use of non-invasive ventilation. So just to emphasize on the idea, when they implemented non-invasive ventilation, so when CPAP went up, the rate of invasive ventilation went down. And then this is a study that looked at the economics benefit that came with non-invasive ventilation. So again, it was a historical comparator, pre and post implementation of non-invasive ventilation. And overall, they documented that there was a reduction in the overall PICU costs. So that summarizes the benefits or the advantages of non-invasive over invasive mechanical ventilation.
Good. Thank you, Dr. Kholoud. So after knowing the advantages of NIV and high-flow nasal cannula, can you tell us more on how we can initiate or how to initiate NIV, and after initiation, how the monitoring is done for such interventions?
This is a very important question. So I think if you have, if you are starting non-invasive and high flow, you need to answer these questions, or you need to have an algorithm of how to initiate these treatments. So before we start on non-invasive or high-flow nasal cannula, we always think about excluding contraindications for non-invasive and high-flow nasal cannula. So the contraindications then are hemodynamic instability. So children on hemodynamic instability are contraindication to non-invasive and high-flow. Children with encephalopathy and those who are unable to clear their secretions are contraindications for that. Significant hypoxemia, when your BF ratios, your PO2 to FI2 ratio is less than 150, that is ARDS, is a contraindication to its use. Children who has recurrent and significant apneas are not good candidates for that. Those who has facial deformities are also excluded from that. Patients who have active gastrointestinal bleeding are not the people to put onto non-invasive ventilation as well. So the first question that we always have to answer is my patient having contraindications before we proceed to the indications? So starting high-flow nasal cannula treatment is probably easier in comparison to non-invasive ventilation. So in infants, high-flow nasal cannula is started as 2 liters per kg per minute. For a child, we usually go to 1 liter per kg per minute, with flows of about 20 to 30 liters per minute in children. Now, it all depends on the maximum flow rate that you have on your blender, but there are oxygen blenders on the high flow that would go to 40 liters per minute. So use that for adolescent. In adults, they can go up to 60 liters per minute. Now, coming to your questions, how should we initiate non-invasive ventilation? So general rules is we start with smaller pressures and then we start increasing them gradually over 30 minutes. Because remember, those are awake children, and therefore you want to make them used to the treatment. And therefore we start with smaller pressures and then you gradually increase. As we do that, we assess the work of breathing, we assess their oxygen saturation, and we assess whether they are able to generate good tidal volumes. The use of CPAP, which stands for continuous positive airway pressure, or a BiPAP, depends on the type of respiratory failure and the type of respiratory condition that they have. These are the guidelines that comes from the respiratory group of the Spanish Society of Pediatric Intensive Care Guidelines. And this group has done a lot of work in terms of deciding the treatment, initiating treatment, monitoring treatment. So if you look at the slide on the left, it talks about type 1 acute respiratory failure. So type 1 acute respiratory failure stands for patients presenting with hypoxemia. Those kind of patients needs to be started on CPAP, so continuous positive airway pressure. So remember what we discussed earlier, that we start with something like small numbers, like 5 centimeters of water, and then you gradually increase those. The FiO2 usually is started at a high fraction, like 50 to 100%, because you are wanting your oxygen saturation to improve until your lungs recruits. So if there's no improvement in the work of breathing, we go to bi-level support. And in bi-level support, you need to decide about your your peak inspiratory pressure, as well as your EPAP or your CPAP. And again, the general rules apply. So you start with smaller pressures and then you gradually increase them, and you evaluate the work of breathing, you evaluate their tidal volumes. When we set their respiratory rate, usually we go 10 breaths below their actual breaths. For type 2 respiratory failure, we usually go straight onto bi-level support. The only exceptions when we go to CPAP is in patients with apnea and bronchiolitis. Those could benefit as well from CPAP in a context of type 2 acute respiratory failure. So coming to the next question, which is really important. So if you are starting non-invasive ventilation in high flow, a very important question that you need to answer is my patient responding? And when should I expect a response? So the clinical improvement is usually seen in vital signs and the work of breathing. So again, this is emphasizing the idea that we should be continuously monitoring the patients for their work of breathing, as well as their heart rates and respiratory rate and oxygen saturation. Majority of responders would show a response in 60 minutes to 90 minutes. And this is based on physiological trials that comes primarily from bronchiolitis patients. Another trial showed that there's a clinical improvement which is shown by decrease of 20% in vital signs. So this means that if you are starting with something like a heart rate of 180 per minute, and you have a patient who is responding, the heart rate goes to something like 165. This is coupled with an improvement in the work of breathing and oxygen saturation and gas exchange as well. So if you look at the slides on the right side, this is an example of that. So after starting high-flow nasal cannula in patients with bronchiolitis, they assessed the respiratory rate, and following the first 60 minutes, there was an improvement in the respiratory rate, heart rate and respiratory rate in responders. Therefore, if there is no clinical improvement in 90 minutes to 2 hours, we should assess whether those patients require an escalation in their respiratory care. So whether they require to be intubated for that. And safety here is very important. So if we are starting new treatment, we need to remember that we need to assess our treatment within this time frame.
Good. So just from the last point you have discussed, Dr. Kholoud, one of the concerns for the use of NIV is the risk for failure. And that risk, which may lead to delay in the initiation of invasive ventilation. Is there any clinical or patient factor which can predict which patient who most likely failed and we need to move to the next level of support, which is invasive ventilation?
Yes, this is very important. So we need to know the responders versus those who are not responders. So there are risk factors for NIV failure. So when before we start treatment as well, we need to assess whether the patient is a good candidate for NIV or not. So patients, these are namely the risk factors for NIV failure. So the first point is, if you have a multi-systemic involvement versus an isolated respiratory disease, you have more chances to fail non-invasive ventilation. So to explain that, if you have somebody with bronchiolitis, this child is probably have a better chances to succeed in comparison to a child who have chest infection or chest involvement, as well as hemodynamic instability, as well as sepsis. So in other words, if you have higher severity scores on admission, so you have a patient who is having multi-organ dysfunction, the chances of NIV failure goes up. The second point is a non-improvement in vital signs. So remember, we always say, assess your patient continuously, assess them within 60 minutes to 90 minutes. The assessment that you need to do is clinical. So you need to evaluate their workup breathing, their accessory muscles use, their vital signs, their heart rate, their respiratory rate, and their oxygen saturation. So if they are not improving, you need to think about transferring them to ICU if they are not in ICU, or whether you need to intubate them. The third point is higher FiO2 requirements. So if you have somebody with higher FiO2 requirements, which is more than 50% following the first 2 hours of treatment, those are the people who are likely to have significant hypoxia and ARDS. And ARDS is one of the risk factors for failure of non-invasive ventilation. So this is a very good study. Yeah, so this is a very good study. This is a prospective epidemiological study that looked at 116 patients who presented with mixed respiratory diseases. Overall, in this cohort of patients, the NIV success rate was 84.5%. This table illustrates the differences, physiological differences between those who succeeded and those who failed. So if you look at the third point, PRISM score, and PRISM score stands for severity score. And the higher the severity score means the less chances for success. So those who had success had a less severity of illness on presentation. With the heart rate at 24 hours, patients who succeeded had a lower heart rate at 24 hours and a lower respiratory rate at 24 hours. And the EPAP, which was used at 24 hours and 48 hours, was significantly less than patients who failed. Remember that you need to evaluate their drop in the vital signs. So in this study, they found that the group who succeeded had a decline in respiratory rate in the first 1 hour. Now, moving to the other features, the FiO2 at 1 hour was higher in those who failed. So it was 50%. At 24 and 48 hours, it was still higher for the failure group. And similarly, those who succeeded were able to improve their CO2s subsequent to their treatment. So this is just to summarize it. So if you see the decline in the respiratory rate, it is maximal after the first 1 hour, and then the responders will continue to drop their respiratory rate throughout the subsequent hours. So to summarize that, the risk factors to fail non-invasive is having a severe disease on admission, a non-improvement in your vital signs and workup breathing, and ARDS, or higher FiO2 requirements. In those kind of patients, you have to be vigilant into moving them to an ICU setup if you have a setup which is outside the ICU, or you have to think about instrumenting their airway earlier.
Good, excellent. So the next discussion point, does different lung pathology like bronchiolitis or pneumonia or severe pneumonia with RDS behave differently with NIV?
Yeah, so this is again a very good question. So, and you probably need to think about selecting your patient when dealing with non-invasive. So different diseases would behave differently. We have an overall success rate of 77% to 77.5%. This is coming from large studies onto pediatric non-invasive, which is multicentric. if you look at the bronchiolitis success rates, it's about 80 to 90%. If you look at something like ARDS, your success rate goes down to something like 30% to 50%. And therefore, you need to choose your disease. If you decide that you are going to choose ARDS, for instance, although it's a contraindication, you need to be having a careful monitoring in an ICU setup. And you should not cross 1 hour. So you need to decide an intubation, after the first 1 hour of treatment. And in between, we have variable success rates. So for pneumonia and acute chest syndromes, they still have good success rate with that. And as a post-extubation, non-invasive has a good success rate as well. So to summarize this is a graph that comes from one of the largest NIV studies. So the dotted line, this one, designates failure. So if you look at asthma had 0 failure. If you look at ARDS, it went up to something like 30, around 25-30%. If you look at something like bronchiolitis, their failure rate was close to 5%. So different diseases behaves differently. And therefore, you need to choose your disease for non-invasive.
Okay, excellent. So also one of the common issue with NIV is the level of nursing care, especially if we are starting such intervention outside pediatric ICU. Can you tell us more about this aspect?
Okay, so this is a very important question. So nursing patients on high-flow nasal cannula or non-invasive in respiratory units outside pediatric ICU has been studied as well. And it has been studied from a resource planning and resource management, because, having respiratory units that deals with those patients and having to reduce the escalation to PICU helps ICU to look after sicker patients. Therefore, the studies basically primarily comes on high-flow nasal cannula treatment, because it's very commonly used outside the intensive care. As for non-invasive, there are some limited studies of non-invasive outside pediatric ICU. So most of these studies, as I said earlier, comes from high-flow nasal cannula treatment. And as for high-flow nasal cannula treatment, there is an increase in the use of high flow outside of pediatric ICU. So this comes from one of the studies that evaluated the use of high flow in European countries. They found that about 53 to 85% of general hospitals would use high flow nasal cannula outside of pediatric ICU. When it comes to the level of nursing staff, they reported something like 2 to 3. So you'll have a nurse for every 2 to 3 patients. And for them, they reported that there was an improvement in the patient status. There was a treatment, and they did not encounter significant complications. There are some studies that came from European countries, primarily on CPAP use in bronchiolitis patients, and they reported also good success rates outside the pediatric ICU.
Good. So that will take us, Dr. Kholoud, to discuss about what is the risk factors, what kind of clinical evidence we need to consider when we initiate NIV or high flow outside pediatric ICU. And that, again, will be a very important point, so we can rationale the start of this intervention and to decide when we should escalate for the next level of intervention.
Yeah, so risk factors for failure of NIV or high flow outside of PICU is so basically patients who are so we have, as I said earlier, we have more trials on high flow nasal cannula in comparison to non-invasive. The risk factors of failure would be those who are not improving in the work of breathing and in their vital signs. So if you have children who has non-improvement in their vital signs within 60 to 90 minutes, they should be referred to PICU. So this is very important. Then cardiac disease. So some of these trials on high flow found that cardiac disease was a risk factor, for high flow nasal cannula outside of pediatric ICU. Therefore, those kind of patients are probably needs to be very closely monitored. Having higher FiO2 requirements also is a risk factor for failure. So if if there's a risk factor of failure, it means that you need to think about escalating your level of care to ICU. Third point is increasing the severity of disease. So you don't want to have a septic patient who is tachypneic onto non-invasive outside the pediatric ICU. And if you are going to do that, there has to be a careful monitoring, and there has to be an endpoint to it. And we need to decide about it, within the first 30 minutes, 1 hour. So multi-organ involvement then is another risk factor, and that emphasizes the same risk factors that you have, for non-invasive failure anyway. So any risk for or any failure or risk factor for failure of non-invasive in general would be the same risk factor for failure for patients outside the ICU.
Good, thank you. So Dr. Kholoud, can you share with us for the units where they don't have the facility or the service to have NIV and high flow not yet established, to establish such service? Can you share with us your experience?
Okay, so I'll talk briefly about requirements. So what do we need to do to set up a non-invasive ventilation unit? So what are the prerequisites of starting a non-invasive high-flow nasal cannula as a new surface? You basically need your need analysis. So you need to know why you want to start non-invasive ventilation. Do you want to do that because your resources in ICU is busy, and therefore you need to move some of those patients outside of your pediatric ICU? Or do you need to do it for other reasons, like you don't have ICU in your premises? We need to have team engagement. So the idea, the plan needs to be engaged with the whole team. You need to have a literature support that says, the diseases that you are going to target are amenable to non-invasive and high-flow nasal cannula. Therefore, you are going to choose diseases which are going to have good success rates onto non-invasive and high-flow. You need to have provider agreement. So you need to have your physicians, your medical officers, your other consultants, and your nursing all on the same page about starting your project. You need to have economic justification. So remember that you will have equipments which are needed for your project. And this is, interfaces, something that needs to be replaced every few months. And therefore, you need to have an economic justification, like, using non-invasive outside pediatric ICU is going to lead to shorter stay. And therefore, we are going to spend less on those patients in comparison to patients who are invasively ventilated. Or the other justification for it is we are going to use it because we don't have enough resources in ICU, and we are going to use it for people outside the ICU. The fifth factor, which is very important, is leadership and personnel. So you need to have a leadership over that project. So whenever the project becomes weaker, or you feel that it needs to enhance more, you need to have people who are going to lift it up again. You need to have training before you start your treatment, because it requires a hands-on. People need to know how to deal with the patients, with their interfaces, with the ventilator. So remember your 4 E's. Remember to engage, educate, and then execute or do your project, and then evaluate it. You need to have protocols for treatment delivery. So ready and set, disseminated, read, and discussed with your whole team. You need to have location and monitoring. So obviously those are sick patients, and you are going to need a continuous monitoring over their vital signs and their blood pressure. So you need an area which is capable of doing that. And then you need to assess the outcomes and then feed it back to the group. So every few months, we should go back to the team and say, we have been starting the surface. This is what we found. We thought, we had the benefits of such and such. And so we have to have a periodic feedback about the outcomes that we have, as well as the challenges, limitation that we encountered.
Good, excellent. That's really very informative and helpful. Dr. Kholoud, can you share with us some of your experience on using high-flow nasal cannula at Royal Hospital?
So in the Royal Hospital, the high-flow nasal cannula started in 2016. Non-invasive started increasing in use in 2015 onwards. So we started this in pediatric ICU, and then we moved it outside the pediatric ICU. So the next slide comes from our preliminary results on a study that we are doing right now. So we had 299 patients who were studied over 19 months. our population had a mixed respiratory diseases. We had bronchiolitis as our predominant diagnosis, but we had other diagnoses like pneumonia, asthma, as well as other patients with medical comorbidities. 78.2% of the patients who were treated with non-invasive outside the ICU did not require transfer to PICU. So that was no escalation to PICU in 78.2% of patients. 12.7% of this cohort required invasive ventilation. We had variable success rates for different diseases, and bronchiolitis and asthma were one of the good diseases that we had in our registry. In comparison, patients with sepsis, patients with upper airway obstruction did not do well onto non-invasive. The median stay on non-invasive was 2 days for our patients, and we had an overall complications rate of 1.6%. So overall, it was safe for us. It saved some of the patients transfer to the ICU, as well as it was feasible.
Excellent. Thank you, Dr. Kholoud. Is there any more information you would like to share with us, or we can start with the audience questions?
Yeah, let's go for the questions.
Okay, thank you then again. And so for the questions, please, you can write your question in the chat. And the other way, you can ask for permission, then please unmute yourself and go ahead with your question. So meanwhile, if nobody has a question to speak them, I will just go through the question on the chat. So there are so many chats regarding the selection of interfaces. You know, Dr. Kholoud, there are so many interfaces we have on market. Is there any special preference or superiority in terms of which type of interface we use when we apply NIV for our patients?
So this is, again, a very important question. So we say interfaces contribute to success of your NIV. So for smaller infants, we prefer nasal interfaces because they are obligate nasal breathers, and because that is probably more comfortable for them in comparison to the rest of interfaces. So it's more comfy, but at the same time, you have on the expense of having a leakage from the mouth. So they need to keep their mouth closed in order to keep their flow and their pressure to optimize the flow that they are receiving. So this is a downside of using nasal interfaces. We have got the oronasal interface. So the oronasal interface is the interface that goes all around the nose and the mouth. And this is used for bigger kids, so 1 year and above. So the advantage of using that is that it is going to preserve your pressures, but it causes a lot of claustrophobia, meaning people do not like it. Children do not like it on them. The other interface that we use is total face mask. And in total face mask, it encircles all around the eyebrows and the chin. The advantage is that it's going to preserve your pressures. Some of the people would find it more comfortable to children in comparison to the oronasal. And there is the helmet. And the helmet is something which is more sophisticated. It's used in some centers, but we are not using that. So more effective interfaces will be the ones that preserves the pressures, but then you have to balance it with how comfortable they are. So for the high flow nasal cannula, obviously it's nasal bronchs. And one of the differences between high flow nasal cannula and non-invasive is comfort level. So there are studies that compared the comfort level between high flow nasal cannula and non-invasive. And they found that there was the comfort score for children was higher for patients on high flow nasal cannula treatment, because basically it's not bulky, it's tolerable, it just resembles a nasal cannula, and it delivers heated and humidified mixture of air and oxygen.
Good.
Does that answer the question? Okay.
Yes, absolutely. Okay, another question again for the interface is asked by Samah Al-Malki. The summary of the question: if you start the intervention with one interface, let's say with the nasal mask, and that was available at that time, and the patient did not show significant improvement, Is there any role for escalating the care by changing the interface, let's say, to a full face mask or to the or to the oronasal mask? Is there any clinical evidence for any clinical improvement and steps need to be taken, or no, that's considered a failure of NIV and we need to go ahead for invasive ventilation?
So you could change in between the interfaces, especially if you are not, if there is a lot of leakage and if the patient is not comfortable, we could potentially do that. But if you have, if you want to be safe with that, so if you are wanting to trial it and you're not sure that the patient is responding or is it interface related, you always have to watch them over the coming 30 minutes and be prepared for invasive ventilation. But you could change over the interfaces. So if there's excessive leakage out of the interface, you are thinking that you are not delivering the flows that you are planning to deliver, then you could potentially change the interface with very careful monitoring over the patient.
Good, excellent. A question by Galaxy A50. The question says that most children in PICU are sick or hemodynamically not stable. It is absolutely contraindicated, or we can consider NIV in some patients.
So there is, to my knowledge, there is no cutoff for how much inotropic support they should be. But the general rule is if they are hemodynamically unstable, then they are a contraindication. Sometimes what we do, in patients with heart failure who present with cardiogenic shock is that you start them on non-invasive and you start them on inotropes as well. So if there's an improvement, a clinical improvement in their blood pressure, as well as their work of breathing, and there's no escalation of their inotropic support or increase in their work of breathing, probably you could wait on those patients and monitor. So there's a proportion of patients who present, mainly the cardiac patients, because this is one of the indications. We use it for heart failure. We use it in patients who has myocardial. So if we start inotropes and we start on non-invasive, if there's a settling of the hemodynamic status and no further escalation, probably you could continue monitoring. But the general rules is if you have somebody who's hemodynamically unstable. So take, for example, septic patients. Those patients, you should think about early invasive ventilation.
Good, excellent. Another question by Dr. Najwa. It is about the use of NIV in palliative care. So the question is how frequent you use it, referring to NIV as part of palliative care. And is there any specific criteria to put such patients on NIV?
So I don't have an experience with the subject, unfortunately. So most of what I have done is more related to the acute respiratory failure. So I don't have, I don't have an answer to that question.
Sure. Another question by Umayma. Sure, about the sedation in patients who have been convinced on NIV. Do you suggest any sedation or specific sedation which will be appropriate for patients who are on NIV?
So if you review the literature, majority of the people use dexmedetomidine, which is an alpha-1, alpha-2 agonist, basically preserves your respiratory drive. And at the same time, it's an anxiolytic. But this is something that you probably could do in the PICU. So if I have the choice, the first thing I would go for Prerequisites. But this is something that we need, under monitoring areas. You could use any other sedative agent. So if you look at the description that came from the Spanish group, they have used things like benzodiazepines. They have used things like morphine. But these are smaller doses. So we have to always balance that with the fact that this could potentially lead to respiratory depression. So our practice, we try to stay away from benzos and morphines because this has the potential of respiratory depression. So we go for something like chloral hydrate, ketamine. But obviously, ketamine can increase your secretions. It can induce hallucinations. And we go for Prerequisites. So if in the ICU, I would go for Prerequisites as my first line, as well as chloral hydrate. But there is no, there's no wrong and right to that. You could use any type of sedation, but if you are using medications that are potentially respiratory depressant, you have to use them in a very small amount. You have to be careful with them. But if you are there in the Royal Hospital, we try to stay away from that. So I think different institutions would have different regulations, which has to be agreed by the different teams.
Good, excellent. Another question by Dream. Is there any specific precautions on using NIV for decompensated heart failure?
So heart failure is one of the groups where we use non-invasive ventilation. But then by decompensated, if you are talking about somebody who is hemodynamically unstable and hypotensive, this is again a person who is severe on presentation, who may be failing, who may be a risk factor for failure. So in heart failure, yes, it's an indication for initiation of non-invasive, but those who has hemodynamic instability has to be watched very carefully.
Good, excellent. There is no more question on the chat, but we have around 7 minutes. So I have simple questions, Dr. Kholoud. Now, when you have a sick patient, let's say with pneumonia, and the plan to start a non-invasive ventilation. Now, is there any time frame where the decision should be taken? Let's say a child admitted to ICU, the plan to start an NIV, we have recorded the initial vital signs. Then when should be the next assessment to decide this patient should continue on the same support with an NIV or no? Now, I think it is enough. We need to proceed for invasive ventilation. Time-wise, is there any recommendation when we should have that decision?
So they have to be continuously monitored. So you need to make sure that your group would inform you if there's a deterioration. And the timeline, I think if you are outside the ICU, and as a general rule, 60 to 90 minutes is your deciding point. There are people who might improve at 4 hours or 6 hours or 12 hours, but you have to be comfortable enough to say, that I would continue monitoring them or I'm going to intubate them. So again, we go to the rule of 60 minutes to 90 minutes to make your decision. And if you want to make a decision of monitoring, you need to make sure that the most experienced person in that area has agreed to that plan. And it needs to be done in the BICU and not outside the BICU.
Good, excellent. One more question from Aida and Muzain. The question says, can we start cardiac patient comes with respiratory distress due to bronchiolitis, for example, with high flow nasal cannula? And what about if our impression was heart failure? Is there any difference in the decision?
So it depends on your level of distress. So there are studies that looked at differences or the outcome of high flow versus nasal CPAP. And that comes basically from bronchiolitis studies. So non-invasive ventilation in general was quicker to resolve respiratory distress, or non-invasive ventilation. So non-invasive ventilation was quicker to resolve respiratory distress, while high flow nasal cannula was more comfortable to the patient. So probably if you have somebody who has mild to moderate respiratory distress, you could still do your high flow nasal cannula. But if you have somebody with significant respiratory distress, you probably would like this patient to go onto non-invasive ventilation straight.
Good, excellent. I think that's answered the question. Is there any more questions, or we can just close up here? There is no more in the chat right now. Anybody want to say the question, and we'll get unmute permission? So there is a question for the last moment from Galaxy A50, sorry, from Khalda 88. Why an IV is contraindicated in patients with apnea? Let's say neonates comes with apnea.
So the apneas which are contraindicated are significant apneas. If you have somebody who has frequent apneas, or significant apneas leading to significant desaturations, those are the kind of people who are probably should be invasively ventilated. If you have somebody who's presenting with apneas, and then after initiation of non-invasive, they stabilize and they had no further apneas, you could continue monitoring them. But again, those are the people who needs to be in the ICU. So it's more related to controlling their breathing and to control their breathing drive.
Good, excellent. I hope that answered the question of Khalda. Thank you so much, Dr. Kholoud, for very informative and very clear presentation. And I would like to thank all the participants who participated with us today in today's discussion. I think we already approached 8 p.m. Thank you so much, and see you in the next session next month.